I think this is what it seems like. So some of these slides are from friends of mine, and I think this is what most non-surgeons feel like, right? Which makes sense because we all know the endarterectomy still is the gold standard.
So if you give them a moment, they're going to put up the QR code.
Okay, sure. Before I get to the cases. So let me just go through these real quick. A lot of this stuff has already been described, but I put the slides down because I think we've already gone over this, so I'm going to move forward from the gold standard. I think endo is ready for its moment, but we need more data. We need to figure out techniques, treatment options, and so forth. We've obviously got various CFA classifications now as a result of endovascular therapy becoming much more commonplace than before. We've obviously got all the CFA trials in terms of endovascular therapy, some that are completed, some that are online and ongoing, and really a lot of these are out to 2-3 years and so forth. So it'll be very interesting to see what happens. So this you can look up later, but I wanted to show you as much as I could. We've already touched upon the edema classification, right, to try to give us an idea of how do we classify CFA lesions when they extend above the inguinal ligament or, inferiorly into the profunda and proximal SFA, and obviously the modified edema classification, which removed really bypass in category 4. Showing the case that Dr. Schmidt-Andre is showing now is there are some isolated profunda revascularization studies, but really nothing that's real robust. I know most people will know that they've intervened on the profunda in cases of rest pain. Maybe it's not a great surgical candidate and so forth, and obviously those do quite well. And I think we have some early data, but really nothing concrete or definitive in terms of isolated profunda revascularization. So now, let's get into the cases. Now, the one thing I want to say, the rules of this are, as we start, is every patient is an operative candidate here. So now you have to really put your thinking caps on and really tell me why you would do endo or why you would do endarterectomy with patch and so forth. So the QR code is now up, it looks like. Yep. So if you scan that QR code, you'll be able to participate in the survey as audience members. Here's case number 1, CLTI patient, diabetes, CKD, low EF, 30%, under 30%, edema 2, Rebellino 2, SH. So this looks like an isolated CFA lesion. So how many would fix this endovascular after everything you've heard? And how many would do endarterectomy with a patch? Ah, there you go. Really? Wow, 70%. All right. So now let's take it down the panel. We did the poll question. Now what about the discussion? So maybe some of our expert operators can weigh in on would they treat this endovascularly or surgically in your practice, and how would you decide, knowing that the patient can get both?
I mean, to me, this is endo because she has CLTI, so she has other levels of disease. It's urgent. She's also over 80, so even if she were, let's say, her EF was normal, as an octogenarian with CLTI, I think she's better off with multi-level endo. The other thing is the bifurcation of the profunda or the common femoral does not appear to be involved, which for me is more challenging when you get a so-called type 3, and when we had this beautiful French street fight here between these two guys, both surgeons, which is fantastic, very poetic. The two surgeons arguing about endo and open for common femoral. But I think in this case, and you can see a lesion right there in the SFA that you would probably just go on and treat. Probably there's more that you will treat endo.
Yeah, I'm going to be faithful with Jan stock still, and I'm going to say it's endo because it's isolated CFA. It's not involving the bifurcation. I agree with Dr. Snyder on that. And again, the age of the patient. And I think...
I think Peter made a good point.
Dr. Broadman,
This is also my assumption here. Maybe we only see this picture here. Maybe there is a lot more disease in the superficial femoral artery and the popliteal artery. And she's a CLI patient, so you want to solve everything at the same time. And therefore, 80 CLI, I would go for endo first. This would be my decision making.
Yeah, no, I think that makes great sense. And you're right, there is multi-level disease, and I think many of us would really treat this endo just because we can treat everything downstream at the same setting. You could make the argument for a hybrid approach, but given the age and some of the comorbidities, maybe you don't want to operate. So this was treated by another operator. They did laser, they did POBA, DCB combo, and they got a quite good result from an endovascular standpoint in terms of debulking and so forth, and obviously got good, and obviously treated the downstream disease. So case number 2, remove the hostile groin, sorry about that. 70-year-old gentleman with CLTI. Now here's the lesion. So CFA disease, looks like distal CFA disease extending into the profunda, proximal SFA. How would you tackle this one? Again, CLTI patient. So we're assuming there's distal disease, but for argument's sake, why don't we say it's a claudicant? A lot of people changing their mind, wow. All right. It says 75% would treat this operatively. Can you go back one slide, please? Let's discuss. What about this one, if you had a claudicant?
So
I think CLTI, I think a lot of people would make the argument for endovascular therapy, but maybe we can just make it a little bit more challenging if this was a claudicant.
for claudicant or CLTI, here surgery becomes an option. Because I'm assuming there is a stent in the SFA, am I right?
Yes.
To the level of the ostium?
Yeah.
That complicates the things because anything you balloon there is going to shift into the profunda. There's going to be a significant plaque shift, especially if you think it's instant stenosis in the ostium and proximal part of that SFA. We have seen this a lot of times, and it just shuts down the whole profunda and makes it complicated for you. So I think here surgery might be a good option, especially you can do a repair of that distal end. You can do a profunda repair, profunda patch, and then also probably repair the proximal end of the SFA at the same time. I don't know if the surgeons...
Yeah, I think for this one, I would recommend having this done open for sure. CLTI patient, there is proximal profunda disease. You want to do a good profundoplasty in case something happens. You'll have at least a flow from there. If the patient could not tolerate it for whatever reason, and I was going to treat this endo, I would definitely do a buddy wire technique here if I had to do it endo.
I think you probably need kissing stents here. The other thing is it's a longer lesion than what it looks like because it starts really at the origin of the common femoral. And we don't know in this view how much narrowing is there, but it looks like it starts right at the iliac circumflex. And then it extends down, looks like 3 centimeters into the SFA. And that kind of disease at SFA origin is really hard to get a good result without a stent, I think. So I think it's more extensive than what it looks like in this picture.
Yep. So this was treated by... anybody else? Yep, please.
In terms of anatomy, which is very important to understand, in fact, the risk of stenting crush is located when the sartorius muscle crosses the SFA. And in fact, you have a mechanism, external compression of the SFA at the location of the sartorius muscle. But usually, according to the level of the bifurcation, the sartorius muscle crosses the SFA 3 to 4 centimeters below the bifurcation. And so it's why in this indication, when you use a kissing stent, it works, but you should use very short one, 12, 18 balloon expandable stent. And so there is no rush of stent crushing. If you have some instant stenosis or thrombosis, I don't know, you can do, of course, after open. And if you make endarterectomy, it doesn't matter because at the same time that you remove the plaque, you remove the stent, so it doesn't matter. And to be honest, we didn't do so much open after this kind of endo treatment.
Great discussion, great discussion. So this was treated by a good friend of ours who's really a good operator, and again, there was a debulking that took place along with some therapy, and then you can see he did, similar to what a lot of us thought you would have to do, is you're going to need stents, and ended up stenting the profunda as well. So, how durable is this? I think we have some early data, and we'll find out. So final case, let's go through this quickly. 81-year-old gentleman referred by an outside vascular surgeon for right leg lifestyle limiting claudication, ABI is 0.6. Did set for 3 months with no improvement. The surgeon that saw him said that, you're very active, and, he does a lot of tours in Europe and Asia. He was leaning against surgery, but, we thought surgery would be the best option. But here are some of his risk factors: heavy smoker, hypertension, hyperlipidemia, all the usual stuff, previous PCI, AFib, is being medically managed at this point. Labs were the normal, and someone had stented his right common iliac artery a few years before, and then the vascular surgeon told him that based on this, I'll show you this. Here's the CTA. And then based on this, given the degree of calcification, the outside vascular surgeon was worried that he would be a high perforation risk when trying to get surgical control of the inflow if he did an endarterectomy. And so I saw this patient and then sent the patient to our chief of vascular surgery at our institution and said, can you treat this patient? I think a hybrid would make the most sense. And you can stent that external at the same time, which is very tight. Or if you don't feel like you can clamp safely, then maybe we go up and over, put a balloon, and occlude the inflow. What are the panelists' thoughts on should this be treated surgically, meaning hybrid or some other variation, or endovascular? And the vote's in. So with that extra knowledge, is everybody still saying endovascular versus surgery here? So it looks like 32% endo, about a third still wanted to treat this endo.
Yeah, I think as good as we want to say it's surgery because it's very calcified, but I think the point that the vascular surgeon made is accurate. It's difficult to clamp these. You have to find a good clamping zone for these, and you can crack the plaque when you're putting your vascular clamp on. So we're just seeing this isolated one, but we would have to see where your clamp zone is going to be in the iliac. Nothing in that picture is really that clampable based on that.
So you're leading towards endo, Dan?
Maybe.
Okay.
But by open, it's not so easy also because the plaque is pretty above the inguinal ligament, and so to get the plaque by endarterectomy, you don't see so much the stop of the plaque, but it doesn't matter because we are in the good flow. But at the same time, we have a plaque at the first centimeter of the SFA, and in this case, it's not so easy to stop the plaque. You have to cut the SFA to make eversion and to make another suture. So it's not so easy also. I am not so concerned by this use calcification. I am always surprised to see when you perform balloon angioplasty, you externalize, in fact, the plaque. I am pretty reluctant not to treat this lesion by endo, but in case of restenosis, after a bypass from you have a prosthesis between the arterobifemoral bypass and the common femoral artery, it's always very fibrotic. And by endo, you don't achieve good results. And so in this case, I go by open. But here, I am not so reluctant due to this huge calcification.
Anybody else? Okay. So you can imagine, we did the poll already, but you can imagine that by the time this patient saw our vascular surgery chief, he was already scared out of surgery and said, no way does he want surgery at that point. And so patient was sent back for endovascular treatment in this case. So we did the discussion. You can see some more pictures to show you that there's really a lot of calcification. So in this case, we did, what Dr. Broadman was recommending on one of the previous cases. We have a wire in the SFA, wire in the profunda. We wanted to be extra careful, extra safe, because we are dealing with a gentleman who's not in too bad a shape, but he is very active, and he's a claudicant. We don't have a wound. We're not dealing with, CLTI. We're not dealing with rest pain or anything like that. And so here's the IVUS to show you what it looked like after IVL. So this was after the maximum number of pulses with IVL. And you can see that it made a little bit of a difference, but not too much. So at this point, what would you all do? What are the options here? This is IVL, significant recoil.
So I think it's more of a recall than I think anything. So I think if you put at this point, if it's just a recall and your balloon expanded well without any apple core, it's not like an apple core lesion where you have to break. So I think here putting a platform would probably solve the problem, especially a stent like Supera would probably take care of this issue with a good radial strength.
Yeah, I think most would agree.
Yeah.
Most agree.
Unless
Supera stent or some other type of scaffold.
The Supera stent if necessary,
Okay.
but after IVL.
After IVL. Is that?
after IVL.
Yeah.
IVL won't have any action here because it's not concentric lesion, it's really
100%.
brachioeccentric lesion.
100%.
That's why at that point we need to have the discussion on if we decide, endo also, this is a technique because That's why we need to analyze very carefully the axial slice before the procedure, because if it's a very thin calcified lesion plus sort of coral reef, that makes sense to practice endo. It's a very rocky, eccentric lesion, very stenotic. I think this is a pure place for the open surgery.
Yeah, great point. So in effect, we basically treated the external with a stent, used a covered stent in this case, and then did a supera stent beyond that. We had to extend it, unfortunately, into the proximal SFA. And then you can see at 5-year follow-up, his ABI is 1. He's still active, doing well on duplex. The stent is open. There's no stent fracture, as we discussed earlier today at 5 years. And his profunda is still patent as well, so he seems to be doing well in this case. Thank you.